All right. Hello, Holistic. Today we'll be talking about palliative care for end-stage heart disease. This is a rather important topic, um, and we're going to explain why in just a second. Um, these are the objectives that we'll be talking about. We'll start with uh, an introduction about congestive heart failure or chronic heart failure. Chronic heart failure is the presence of symptoms of heart failure at rest or during exercise, and objective evidence of cardiac dysfunction. And usually this is done by echocardiography. In the Western world, ischemic heart disease predominates, while in other areas you might find other, heart diseases causing, the chronic heart failure. Why it's so important to learn about this topic? Number one, because it's so common. And number two, the symptom burden is pretty high, which include, dyspnea, fatigue, anorexia, anxiety, depression, and others. In fact, patients with chronic heart failure, they have the same, almost the same symptom burden like cancer patients. And this was actually research. So if you look at this picture here, and this is from the WHO actually, you'll see, the incidence of cardiovascular diseases is around 38.47%. And this is versus cancer, which is 34%. So you can see that in palliative setting, cardiovascular and cancer are the commonest two diseases. Prevalence of heart failure is estimated to be 1 to 2%. And as we said, uh, the the burden that the patient is suffering is almost same like cancer patients, or maybe even more. Um, to explain this symptom burden, you have to look at this picture here. When heart failure occurs, there's an activation of the RAAS system. There's increased pro-inflammatory mediators, cytokines, and increased norepinephrine. And this actually will lead to a catabolic state and myopathy. And because of that, you will develop things like dyspnea, anxiety, fatigue, and anorexia. There are two types of heart failure. There is systolic and there's diastolic. With diastolic, there's impaired relaxation of the ventricles, while with systolic, the ventricle is stretched and thin. Sometimes they call it heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Clinically, heart failure will show up as dyspnea, cough, anorexia, ascites, anxiety, fatigue, care dependency, hepatosplenomegaly, and decreased blood pressure and reduced urine output. And this is the typical chest x-ray of a patient with congestive heart failure. You can see the curly B lines, cephalization of vessels, pleural effusion, and increase of the cardiothoracic ratio. Prognostication. The commonest two prognostication scales are done through the American Heart Association and the American College of Cardiology. And I want to mention that there's another one that we're gonna talk about. It's called the Seattle Heart Failure Model. It's kind of more simple, prognostication method. The heart failure, you know, prognostication is like other organ failure. It's kind of unpredictable. It's not like cancer, and very difficult to delineate when to switch from curative mode to palliative mode. Remember these two things during the rest of the presentation, guys. Okay? And the unpredictability of the prognostication and the difficulty finding when to stop the curative and start the palliative mode. This is compared to cancer. Okay? New York Heart Association functional classification, and this is the American College of Cardiology, AHA. The difference basically is with this classification, you cannot go back. I mean, it's not reversible. So if you go from A to B or B to C, you cannot go back to B. While here, you can actually, you can be at stage 4, and then you can go up after treatment to stage 2 or 3. Prognosis of congestive heart failure. As I said, it's unpredictable, but generally speaking, if you're New York Heart Association 1, you have 7% 1 year mortality, while 4, you have 52% 1 year mortality. So basically, patients with New York Heart Association 4, these are the guys they cannot lay flat, basically. Uh, they have almost 50% mortality in the first year. So this is pretty serious. This is the Seattle Heart Association model, and you can, access this in the internet. And basically, you just fill up the numbers. They have clinical scores here, and then they have medications, diuretics, and they have the lab data, and then the interventions, devices, and then they give you a number that you will be able to know what is your survival and mortality. Okay, so as simple as such. This one is commonly used in the United States. Cardiac markers play a big role right now in the prognostication of cardiac disease. So what is cardiac markers? These are intracellular macromolecules released from the heart muscle when it's damaged as a result of myocardial infarction. And the ideal biomarker basically has to be specific, sensitive, reflect the disease severity, correlates with the prognosis, should aid in clinical decision making. So some of the biomarkers for heart failure is the cardiac cachexia markers, such as anemia, inflammatory markers like CRP and interleukin 6, low serum albumin, inflammation like highly sensitive CRP, the interleukin 6, tumor necrosis alpha, procalcitonin, chamber dilatation, like high BMP, and the new one, high NT-proBNP. This is just like some of the important biomarkers that we use for prognostication, but they're coming out with so many things right now. I'm not aware of them, but I'm sure if you're in cardiology, you'll be able to know new things. Again, the biomarkers, the creatinine is also important. Hyponatremia, hyperuricemia, and markers that show myocardial injuries such as troponin and creatinine kinase. This is the difference between congestive heart failure or chronic heart failure and cancer patients. Again, we're not going to go through the whole slide, but to make it easy, there are two things that you need to know about. With heart failure, prognostication is more difficult and it's unpredictable, and uh, there's always difficulty to delineate when you switch from the curative mode to palliative. Sometimes you have to keep using curative, modes, even the patient is getting very near to end of life, and this makes it more difficult. And actually, you need more collaboration with the heart doctor, not like oncology patients where you can take over once the patient switches from the curative to palliative mode. Okay, so how to deal with heart failure in general? I got this nice, picture, and it can show you some of the, medications used early on, like the ACE inhibitors, the ARB, the ARNI, beta blockers, mineralocorticoid antagonists, ivabradine. Then you have here ICD and CRT, mechanically, uh, you know, uh, mechanical support for and heart transplantation. So we'll just go through these quickly. These are the pharmacologic therapies we just mentioned now. This one is SGLT2 inhibitors. This is a diabetic drug that's been shown to be very useful in heart failure. And these are the ARNI or the angiotensin receptor neprilysin inhibitor. Beta blockers, digoxin, hydralazine with nitrates, mineralocorticoid antagonists, and funny channel inhibitors like ivabradine. So empagliflozin or Jardiance. For those of you guys that have a diabetic patient in the family, I'm sure you will hear this name. So this is a diabetic drug. Basically works to releasing more of the glucose in the urine, and they found that this is very useful in heart failure patients. Works mainly on the proximal convoluted tubules. All right. Then the ARNI. The ARNI is a combination of two drugs, valsartan and sacubitril. Valsartan is an ARB, while sacubitril is a neprilysin inhibitor. What does this mean? Means that it reduces uh, the degradation of the natriuretic factors in your body. So your body release mediators that get rid of the sodium, and this medication inhibit its degradation. So you're able to lose more of or you have more natriuresis, more sodium loss in the urine, and thus this will help with the heart failure. These are how they work. Another drug is the hydralazine combined with nitrates, and this is very useful in patients like Afro Americans, uh, because these guys really don't respond to ACE inhibitors. Okay, and these basically resume what we call the nitroso redox balance. Corticoid receptor antagonists like spironolactone, iplirine, and others. These also are very useful in heart failure patients. Uh, And as you see, they work on the kidney, heart, the adipose tissue, blood vessels, and even retina. There are three of them. The most important thing to know is the spironolactone or aldactone. We all use this drug extensively. The only problem is it can cause some, you know, glucocorticoid side effects. Patient can get like, you know, gynecomastia and stuff like that. These new ones don't have such a problem, like eplerenone and phenyrenone. Another medication, ivabradine. This works on the pacemaker of the heart, and this is a replacement to beta blocker. So if you have someone that are manifesting adverse effects from beta blockers, and you want to reduce the rate, the heart rate, uh, this is a medication that you can use. And it can be used in patients with ejection fraction less than 35%, okay, compared to beta blockers, which cannot be used in this condition. The ivabradine works on channel called the IF channel. All right, we'll jump into advanced therapies for heart failure. So we have the cardiac resynchronization therapies, or what we call CRT. We have the implantable cardiac defibrillator, mechanical circulatory support, and then the heart transplantation. So what are the functional benefits of advanced therapies? Number one, improve the 6 minute walking distance, improves the quality of life, reduces hospitalization, decrease the New York Heart Association functional classification. Remember, you cannot change the ACC AHA classification, but you can change the NYHA classification. Improve prognosis and reduces the incidence of sudden death. Like, for example, if you're using ICD. So this makes the prognostication even more and more difficult because you have these advanced therapies that if you use them, you can change totally the prognostication of the patient. So we'll start with the CRT, okay? And this is, useful in patients with persistent left ventricular dysfunction, and they have conduction delay, okay? Like the QRS more than 150 or QRS 120 to 149 plus dysynchrony on the echo. And patients having also ejection fraction less than 35%. This is how it looks like, the CRT. CRT. Now you can actually combine it with a defibrillator, and it's called AICD. I'm sure all of you guys have seen these. The ICD or cardiac defibrillator, and this one, does defibrillate if the heart stops. Basically, is used in patients with ejection fraction less than 35% and QRS between 120 to 149. This is how it looks like. Again, most people use a combination devices between the CRT and the defibrillator. Now, when you get into end of life, we like to deactivate the defibrillator. We do not discontinue the pacemaker, the pacemaker will always continue, capturing. But we would like to stop the defibrillator so the patient, doesn't get shocked at the end of life, which could be very traumatic and painful. Now, usually we call the rep, and the rep comes and does this job for us after putting the, our, the consent and everything, get ready, because this is medical legally important. You have to call the family and get their, approval. If the patient is still alive and he can give the approval for himself, that's good too. But anyway, you can use a magnet if you don't have time until the rep shows up. You can use a magnet. It's available in all ICUs. Okay, this is how it looks like. Uh, Now we're going to talk about another topic, which is the mechanical circulatory support, or MCS. All right. These are really very useful methods, and basically, in patients with refractory heart failure, okay, or used as a bridge for to transplantation. And the overall 2 year survival after MCS usually exceeds 60%. These are the most important ones you need to know as far as I'm concerned. There are other ones as well. The intra-aortic balloon pump, the ECMO or extracorporeal membrane oxygenation, the LVAD or the left ventricular assist device. Intra-aortic balloon pump is mainly used in acute situations like patients with acute congestive heart failure, or a patient coming out of the bypass and you're not able to wean him off, and so forth. The ECMO is used mainly in respiratory failure type 1 and type 2, which is intractable for treatment. We're not going to talk much about them. The most important one that we're concerned with is the ventricular assisted devices. And there's right and left and combined, but the commonest one that you need to know about is the LVAD, or the left ventricular assist device. Okay, so it's increasingly offered right now in patients with refractory heart failure. The reason is it could be used as a bridge for transplantation. In other words, inserted for short or intermediate term, until the patient gets his transplant. It could be used as a destination therapy. Let us say the patient is not eligible for transplantation. You can utilize this technology as a replacement for heart transplantation. It could be bridge to recovery. So some cases are acute in nature, and you can just use this until the patient, overcomes the disease that he's suffering from. And sometimes it's a bridge to candidacy, or until you make up a decision as far as this patient. Into indications of VAD, we base our indications in usually in patients with refractory heart failure that have a myocardial oxygen consumption of less than 14 ml per kg per minute. And this is how they measure the myocardial oxygen consumption on a treadmill, and the patient is breathing oxygen, and they're capable of knowing the peak myocardial oxygen consumption. It has to be less than 14. Ventricular assisted devices um, are very important, especially in palliative care, uh, because before you put a machine like this, palliative care has to talk to the family about the situations where the left ventricular assisted device is not working. So because you need to know the other options. If let us say they put the LVAD and it didn't work. This is basically the LVAD. There are a lot of YouTubes and you can look them up. It's really very fancy, to be honest with you. I'm very impressed with this machine. Now they were able to make it very small. You're carrying like a very small battery, outside, and it's your heart is working, beautifully here with the assist of this machine, without the problems that you get from the transplantation. Okay, heart transplantation is the gold standard. I mean, we cannot say anything against that. Um, it's unfortunately severely limited by the shortage of donors. Now, the prognosis of the transplant patient is fascinating too. At 1 year, it's 88%, 3 years, 79%, and 5 years, 73%. Maybe less so with females. There are two types of transplantation: orthotopic and heterotopic. The orthotopic, you just, excise the old heart and put a new one in. You just keep the atria intact, and you suture the new one to the old atria, the posterior wall of the atria. But with the heterotopic, and this is really very rarely done, guys. This is not the common one. This is the commonly used one, the orthotopic. With the heterotopic, you just implant another heart. It's like a battery. You add it to the original. I got this beautiful picture actually from the net, and this is the first transplantation, done by Dr. Bernard from South Africa in 1967. Very interesting. Okay, so we'll talk about advanced care planning and heart saving. So what are our goals? Our goals are promoting of independence, like communication skills, exercise, and rehabilitation. These are used to promote the independence because unfortunately these patients, they become care dependent. Okay, pharmacologic, cognition, behavior, and mood, caregiver needs, training, supportive therapy, and respite care. So these are the things that we do as palliative care, okay, for these patients. We care for the patient and the caregiver as well at the same time. Um, as we said, uh, it's not about dyspnea. Patients with heart failure develop other symptoms like pain, nausea, anxiety, depression, and a lot of psychological distress. And we talked about care planning. You know, most patients of stage D, this is the American College of Cardiology, will die within 6 to 12 months. So again, the delineation between curative and palliative therapies is blurred. And this is one of the difficulties we have with heart failure patients, besides the unpredictable prognostication. Hospice eligibility. So when do you refer the patient to hospice? Okay, hospice is basically the patients that have less than 6 months life expectancy, and there is no need for curative therapies. This is what hospice means in a nutshell. So you have a congestive heart failure, stage 4 ACC, or stage D ACC, or stage 4 New York Heart Association. Significant symptoms at rest. This is the most important thing that you need to know. You know, high burden at rest. Okay. Patient is optimally treated. Number 2, patient has angina pectoris at rest, resistant to all standard therapies. And then you have other supporting conditions like ejection fraction less than 20%, resistant, treatment resistant dysrhythmias and others. I can, summarize this whole slide in one word. Okay. Patients with congestive heart failure and significant symptoms at first. Okay. And patients are optimally treated. This is basically the hospice eligibility criteria for heart failure patients. So, what are the 10 top 10 symptom burden of heart failure? Dyspnea, cough, anorexia, cachexia, ascites, anxiety, fatigue, pain, care dependency, impaired quality of life, reduced blood pressure, reduced urine output, and oxygen saturation. I remember one of my family members had this, and his his blood pressure was like chronic systolic 70 all the time. Of course, he couldn't get off the chair. Basically, he started to get orthostatic. Okay, dyspnea. In dyspnea we have two types: episodic and chronic, and these are the factors affecting dyspnea. I want to mention that with dyspnea, you start with treating the underlying disease, and you do psychosocial support. You try pulmonary rehab, and then you go to systemic low dose opioids and trial of oxygen if hypoxemic. So this is how you go from a step. It's like this is the baseline, and then you go up. So don't jump on the opioids. The opioids work on the pre-Bolzinger complex in the inspiratory center. It dampens, this inspiratory center, so the patient doesn't get air hunger. Usually, doses we use for dyspnea is much lower than pain. Fatigue is a very common problem, especially guys in children. Fatigue is number one symptom in children. These are different causes of fatigue in heart failure patients. And this is how we deal with it. I want to mention here exercise is important in physical therapy. Non-pharmacologic techniques is more important, and trying to treat the underlying causes. CAS, or cachexia anorexia syndrome. The definition here is a little bit different than the usual definition. Cardiac cachexia is involuntary weight loss of more than 6%. In the old traditional definition, 5% of non-edematous body weight over last 6 months, regardless BMI and in absence of other cachectic causes. So, guys, when you define cardiac cachexia, it's a little bit modified from the original definition. Okay?
حسن
About this. Now,
طيب باقي في التوصيل متى؟
patients who develop cardiac cachexia have a 50% mortality rate.
اي طيب
Again, here the different causes of cachexia: CHF, cancer, COPD. This is a manifestation of cardiac cachexia. Of course, you have a very poor prognosis. If you reach this cardiac cachexia situation, it's basically irreversible, and probably you have very limited, life expectancy. All right. So, what are we doing with these patients? Nutrition, good nutrition, omega-3, good high caloric nutritional supplements, and aerobic exercise training. Medications have less role in cardiac cachexia, but you can try different things, like, for example, testosterone, ghrelin, even ACE inhibitors and beta blockers help with cardiac cachexia. Okay. Um, pain. Pain is common and it's unrecognized and undertreated in heart failure. Okay. It impairs quality of life and it can induce insomnia, anxiety, and depression. Total pain is very common in these patients. And as you know, total pain is the sum of different types of pain, including physical pain and non-physical pain. And this was coined by Cicely Saunders. Okay, we'll end our presentation here. Uh, Key learning points. Traditionally, palliative care models have been designed for cancer patients and are not good fit for congestive heart failure patients, for which prognosis is more uncertain and the distinction between curative and palliative therapies is not clear. I mean, if there's anything I want you to learn today, is this two lines that I just mentioned. Okay? Choosing the best moment to start palliative care is challenging, but focusing on existing needs instead of estimated prognosis may help. So I do like to have a collaborative work with the heart team. Okay, it's not like I'll take the patient, except maybe in the last few hours of like end of life, but I would go and see the patient. I would try to work with them to help with patient comfort. Okay, there is no point to stop all the therapies that in fact could be helping the patient symptoms. um, Regular assessment of physical, psychological, social, and spiritual needs is therefore required. Patients experience multiple symptoms. uh, Again, the high symptom burden, this is one of the characteristics of CHF. Integrating primary or specialty palliative care in the care of patients with CHF can improve patient and family outcomes. Okay, I think I'm done here. Thank you, guys.